Hello and welcome to the Diagnostics of Ischemic Heart Diseases in the Cardiology module. By the end of this topic, you should be able to assess a patient with suspected cardiac chest pain, interpret ECGs and its coronary territories, classify acute coronary syndrome, establish a diagnosis of acute coronary syndrome, identify risk factors for acute coronary syndrome, and finally outline the investigations in acute coronary syndrome. Let's get started. Let's first look at how we begin the assessment of patients with suspected cardiac chest pain. NICE defines anginal pain as the following, where it's constricting and it's a discomfort in the front of the chest or in the neck, shoulders, jaw, or arms, precipitated by physical exertion and relieved by rest or GTN in about 5 minutes. Patients with all three features have typical angina. Patients with two of the above features have atypical angina, and patients with one or none of the above features have non-anginal chest pain. For patients in whom stable angina cannot be excluded by clinical assessment alone, NICE recommends the following. First line being CT coronary angiography. Second line, non-invasive functional imaging looking for reversible myocardial ischemia, and the third line will be invasive coronary angiography. Examples of non-invasive functional imaging include myocardial perfusion scintigraphy with single photon emission computed tomography or stress echocardiography, or first-pass contrast-enhanced magnetic resonance perfusion or MR imaging for stress-induced wall motion abnormalities. This table shows the correlation between ECG changes and coronary territories. Changes seen in V1 to V4 indicates the anteroseptal region. Lead 2, 3 and AVF reflects the inferior part of the heart. Lead V4 to V6, 1 and AVL reflects the anterolateral aspect of the heart. 1 AVL with or without V5 to V6 reflects the lateral aspect, which is supplied by the left circumflex artery. And finally, tall R waves in lead V1 to V2 indicates a likely posterior infarct, which is usually the left circumflex, also the right coronary artery. Now let's look at acute coronary syndrome. Acute coronary syndrome is an umbrella term used for describing a range of conditions associated with sudden reduced blood flow to the heart. Take note, the key point here is the onset, which is sudden in nature. Acute coronary syndrome is largely classified into unstable angina and myocardial infarction. For unstable angina, this type of angina simply means a condition marked by severe pain in the chest. Unstable angina in particular refers to severe chest pain occurring at rest. This condition is caused by obstruction of a narrowed coronary artery by an unstable plaque leading to a small degree of ischemia to the heart muscles. Typically, coupled with symptoms, ECG changes are observed, and these include ST depressions, T-wave inversions, as well as flattened T-waves. Cardiac enzymes are not elevated in unstable angina. As for myocardial infarction, let's look at the first type, which is ST elevation myocardial infarction or STEMI. ST elevation myocardial infarction, as its name suggests, depicts ST elevations on ECG, and this is typically seen on contiguous leads with reciprocal changes. The leads on an ECG represent the areas supplied by various coronary arteries, and this table outlines the localization of myocardial infarction. This is important for clinicians to identify the potential artery that is affected and the following complications which are to be anticipated. Cardiac enzymes in ST elevation myocardial infarction are significantly raised, as one would expect a significant amount of infarct which has occurred, giving rise to significant changes on ECG. It should be remembered that a new left bundle branch block may point towards a diagnosis of acute coronary syndrome. Next, non-ST elevation myocardial infarction. This is another variant of myocardial infarction, and this occurs in the absence of elevation of ST segments on ECG. However, cardiac enzymes remain elevated, reflecting a significant amount of infarct affecting the cardiac muscles. These classifications are important in deciding the mode of reperfusion therapy, which we will be looking at shortly. Risk factors for ischemic heart diseases are well classified into modifiable and non-modifiable risk factors. Modifiable risk factors are smoking, non-communicable diseases such as diabetes, hypertension, hyperlipidemia, obesity, sedentary lifestyle, and cocaine use. As for non-modifiable risk factors include age, male gender, and having a family history of ischemic heart disease. Myocardial infarction in a first-degree relative who is 55 years and younger poses as an important cardiovascular risk factor. Now let's look at the ECGs. Injury to the myocardium can lead to significant changes in the electrophysiology of the impulse conduction in the heart. Serial ECGs help with identifying possible myocardial ischemia and infarct. In STEMI, you might see hyperacute or tall T waves, ST elevation, or new left bundle branch block occurring within hours. T wave inversion and pathological Q waves follow over hours to days. Among the causes of ST elevation include pericarditis or myocarditis, left ventricular aneurysm, Prince-Meadows angina, Takotsubo cardiomyopathy, subarachnoid hemorrhage, and it could even be a normal variant with a high takeoff. ECG changes in a non-ST elevation MI and unstable angina are ST depression, T wave inversions, and it may be absolutely normal. This diagram shows the typical features of left bundle branch block or LBBB. One of the most common ways to remember the difference between LBBB and RBBB is William Marrow, William for left bundle branch block LL with the W sign in the anterior leads and M sign in the lateral leads. And it's the opposite for the right bundle branch block. Other non-ischemic causes of left bundle branch block include cardiomyopathy, hypertension, and idiopathic fibrosis, digoxin toxicity, and hyperkalemia. New left bundle branch block is always pathological and may be a sign of myocardial infarction. Diagnosing a myocardial infarction for patients with existing left bundle branch block is difficult, so the Scarboza criteria is used to help with this. Chest radiographs can be done fast in an emergency setting. Amongst the findings seen on a chest radiograph of one with acute coronary syndromes are cardiomegaly and pulmonary edema due to acute heart failure or a widened mediastinum. Next, cardiac enzymes. Cardiac enzymes are chemical compounds that rise in the plasma level during myocardial ischemia or infarction. Myoglobin can be detected within 2 hours of cardiac myocyte damage, but it's not specific as it is also present in skeletal muscles. The most sensitive early marker for myocardial infarction is the myoglobin. CKMB increases within 2 to 6 hours of onset of chest pain. It peaks within 24 hours and it returns to baseline quicker than the troponins. The sensitivity and specificity are not as high as for troponin levels, and this is useful to look for reinfarction as it returns to normal after 2 to 3 days. Cardiac troponin levels begin to rise in the serum within 4 to 6 hours from the onset of pain, and it peaks at 12 to 24 hours and it returns to baseline over 7 to 10 days. Lactate dehydrogenase or LDH1 isoenzyme is predominantly found in cardiac muscles, so a high LDH1 to LDH2 ratio can indicate myocardial damage. Levels begin to rise 24 to 48 hours, it peaks at 72 hours, and it remains elevated for 10 days. It is not widely used in the UK practice. The most sensitive and specific to cardiac myocyte injury and infarct are the troponins. Finally, to sum up the investigations in acute coronary syndrome, let's look at the non-invasive functional imaging that are available. Echocardiography is an accurate, non-invasive test that enables detection of evidence of myocardial dysfunction caused by ischemia or necrosis. Evaluation of wall motion while a patient is experiencing chest pain can be useful when the ECG is non-diagnostic. Severe ischemia produces regional wall motion abnormalities or RWMAs that can be visualized echocardiographically within seconds of coronary artery occlusion. These changes occur prior to the onset of ECG changes or the development of symptoms. The regional wall motion abnormalities reflect a localized decrease in the amplitude and rate of myocardial contractility. Cardiac MRI, commonly termed CMR, has become the gold standard for providing structural images of the heart. It is particularly useful when assessing congenital heart disease, determining right and left ventricular mass, and differentiating forms of cardiomyopathy. Myocardial perfusion can also be assessed following the administration of gadolinium, and currently CMR provides limited data on the extent of coronary artery disease. Cardiac CT is useful for assessing suspected ischemic heart disease using two main methods, using the calcium score or the contrast-enhanced CT, which allows visualization of the coronary artery lumen. If these two techniques are combined, cardiac CT has a high negative predictive value for ischemic heart disease. Other imagings that can be used also includes nuclear imaging, and this technique uses the radio tracers which are extracted by the normal myocardium. Examples include thallium, technetium, fluorodeoxyglucose or FDG, which is used in positron emission tomography PET scans. So in summary, acute coronary syndrome or ACS refers to a spectrum of clinical presentations ranging from those ST segment elevation myocardial infarction to presentations found in non-ST segment elevation myocardial infarction or in unstable angina. It is almost always associated with rupture of an atherosclerotic plaque and partial or complete thrombosis of the infarct-related artery. In the emergency setting, electrocardiography is the most important diagnostic test for angina. Lab studies, which include cardiac markers, are helpful in the diagnosis and management. Diagnostic imaging modalities also can be used to assist with diagnosis and therapy. Initial therapy focuses on stabilizing the patient's condition, relieving ischemic pain, and providing antithrombotic therapy. Additional therapeutic measures that may be indicated include thrombolysis and percutaneous coronary intervention, which is preferred treatment for ST elevation MI. We have come to the end of this topic. Thank you.